you all for inviting me. I'm a pediatrician at Cincinnati Children's. Erdheim-Chester disease is not something that affects children, but there is a disease that is very similar. And as Dr. Goyal mentioned, these lines that differentiate one disease from the other might be a little artificial and getting blurred. And we will probably stop calling a disease based on what we historically had been calling them, and eventually just turn out to be based on what the mutation is. So just make sure. Okay, so just a couple disclosures that don't apply to this presentation, but the disease I'm referring to, the slides are not advancing on here. Let me just okay, because when I try to go to this presentation mode, it's not. So I just do that. It's not on the screen. It's stuck on slide 2. It's not advancing.
It is not advancing.
Back on the third one. That's mine. That's okay. There we go. There we go. I think now it works. All right, just a couple of disclosures. So this is what I was referring to. The most common histiocytic disease in children is called Langerhans cell histiocytosis. And this is a report from 2019, 3 years ago, comparing the mutation profile of LCH to that of ECD. And if you notice, there's only about 100 patients in each group. They look almost identical. And I think it may be that it's sort of a similar disease that in children we call it LCH and adults would call it ECD, but in reality, the underlying underpinning biology might be the same. So the most common mutation in both these diseases is this. Most of you probably are familiar with the BRAF V600E mutation. The second most common are mutations in the gene called MAP2K1. And then all the other ones are a smattering of a few rare, and if we actually focus, it turns out they're quite similar. So I'm going to take a step back and say, well, what do these mutations mean? How does that apply to this disease that we're trying to study? We're going to take a small, short lesson in basic biology. So we all are made up of cells, which is the tiny element that makes us all. At rest, all these cells are just sitting there, and I call them resting as they're asleep, until there is a measure or a tank of how many cells we need. When that tank gets empty, there's an alarm that goes off. Hey, we're out of cells, we need more. So what do we do? The cells divide. 1 cell gives rise to 2, 2 give rise to 4. And this process goes on until the tank is full and we have enough cells, the cells go back to sleep, back in the resting state. This whole process works similar to a gas tank in a car, where if you run low on fuel, you can see with your eyes that, oh, my gas tank is running low. Sometimes some of us are not very good at recognizing that. So now the manufacturers have added a sound that goes off when your tank is running low. So it's our ears that hear that sound, and it's our eyes that see that tank. We call these things that see or hear as a receiver or a receptor. It's the same word. What happens then? There's a nerve signal that goes from my ear or from our eyes to the brain. There's a nerve cell, and we call that a relay neuron because it's relaying the message to the brain. And then there's another nerve cell in the brain that says, oh, the tank is empty. Now I need to tell another cell, that of your arm, that you need to go and pull up this gas tank to fill your tank. It's almost the same process that happens in a cell. That whole message of the alarm bell that, hey, we need more cells, that message is received by a receptor, which is on the surface of the cell, saying we need more cells. And that signal is then transmitted to the brain of the cell, which is the DNA. saying we need to make more of you. So this mechanism is the relaying of signals that exists in our cells. And I give an example of a relay, like a relay race, but the word relay just means somebody handing something to someone else. In this case, it's a message to grow. That is what all these genes, that is what they do. They are relays. So inside the cell, when the receptor gets a signal, in most of our cells, that signal will hand it off to the BRAF. That's one of the relay proteins, which hands off to the next one called MEK, which hands off to the next one called ERK. And ERK is the one that then goes into this nucleus, which is the brain. That's where the DNA sits and tells the cell, okay, we need to do something now. So these genes, BRAF, MEK, ERK, these are all relays that convey the signal from outside of the cell to inside of the cell, telling the cell what it needs to do. What happens in these diseases, histiocytic diseases, almost all of them universally, whether it is LCH, whether it is ECD, there are several other ones, Rosai-Dorfman, JXG, doesn't matter. There is a mutation or a problem or an error in these proteins. So the most common one we now know is BRAF. And when this error happens, the BRAF signals or activates the relay even when there is no signal to grow coming from outside the cell. So the BRAF is now continuously handing a signal to MEK, even though there's no need for it. The same thing could happen instead of BRAF. The problem could happen in the other most common gene called MAP2K1. That's the same as MEK. It's just the same name we use interchangeably, just to confuse you all, trying to make us look smart. The one way to look smart is to make everyone else confused. We doctors are very good at that. But instead of BRAF, the same thing happens in MEK. It's always on, even though there's no need for it to be on. So what happens when you have these signals that are relaying constantly, even though when the tank is not empty? So this is what's happening. There is no alarm bells going off. There's no need for these cells to grow, but they're growing because there was a problem in the relay. Okay. So on the top here is a normally organized image of a tissue or organ, where you have all these cells sitting normally in an organized manner. This is how things should be. But now all of a sudden you have excess of cells that are growing that did not need to grow. And in histiocytic disorders, where you have these mutant cells, they invite other inflammatory cells to join their party. And there's no room for all these cells. So what happens? They just start growing where they don't need to be. That is the problem in all these histiocytic diseases. You have these mutant histiocytes that have BRAF or MEK mutations that are constantly relaying a signal that is not needed, and they bring in other inflammatory cells. And so this is why we use treatments like BRAF or MEK inhibitors. So there are on the market currently these BRAF inhibitors that are listed on here. If you notice, they all have the word RAF in them, R-A-F. That's how we know that these are BRAF inhibitors. And then we have 3 MEK inhibitors. They all have the word MET or M-E-T in them. That's how we know those are all MEK inhibitors. And there are probably new ones also coming on the market. So there's a huge menu of options to choose from. And just to remind you, this is the order in which the signal starts. BRAF sits on top, then MEK, and then ERK. Just the repetition of what I showed you earlier. So how do these inhibitors work? They're just going to stop the relay. So here you have BRAF V600E running nonstop, even though it's not needed, handing that signal off to MEK. Well, you can use this inhibitor. I'm using dabrafenib as an example, but it could be vemurafenib, encorafenib. It's like a lasso that binds BRAF. Hey, stop. You're not going to hand the signal to MEK. That's exactly what happens now. There's no more signal going. The cells come to a rest. The thing with these BRAF inhibitors, however, is that, as Dr. Goldberg already mentioned, they only work against this one particular mutation, BRAF V600E, which is the most common mutation, but not the only one. There are other BRAF mutations, and I'll show you one example of that. Similarly, if you have a MAP2K1 mutation or a MEK mutation, in this case, the MEK that's running nonstop, handing the signal to life, you do the same thing, bring in that lasso. This time it's a MEK inhibitor. It arrests MEK so that it can no longer hand over the signal to ERK, get the same result. Now, if you've been paying attention, these things have to go in this order. BRAF has to activate MEK, then MEK activates ERK. And so, as just like Dr. Goyal mentioned, even if you have a BRAF V600E, which is a BRAF mutation, you could disrupt or interrupt this cycle by a MEK inhibitor. So a MEK inhibitor will block the relay, whether it is a mutation in MEK or above MEK or before MEK in BRAF. So how does one choose them? So I'll give you one example. We all know, as Dr. Goyal mentioned, if you know there's a BRAF V600E mutation, you can use a BRAF inhibitor. What if it's a different BRAF mutation? Then what do you do? This is what we encountered in one patient a few years ago. This was, even though I'm a pediatrician, thanks to my colleague, Dr. Gupta, at that time, this was a relatively new field. He asked me to step in, and so we jointly treated this young lady. So she had these tumors, one in her neck and one in her groin, and she had multiple other problems as well, but this was easy to show on a PET scan. And this was biopsied, and the biopsy showed, yes, this is LCH, or histiocytosis, and we found this BRAF mutation. So it's not BRAF V600E. And so a BRAF inhibitor would not work, and at this point, this mutation had not been described in the literature, so we were a little unsure of what to do. But we knew that BRAF must go through MEK, so we put this woman on a MEK inhibitor, and this is her PET scan before treatment, and a few weeks later, this was her PET scan. Those masses completely disappeared. In fact, we know because her sister called us and said they've gone after 5 days. And so since then, we've now been asking, could we just use a MEK inhibitor in everybody? Why not just do that? And the reason why we do this is because in children, which is who I treat mostly, histiocytic diseases are rare. And so in order for us to learn which medication to use, we have to gain the experience from treating as many patients as possible. If we select a BRAF inhibitor for those who have BRAF V600E, a MEK inhibitor for all the others, the experience and our knowledge learning gets diluted. It will take about 20 years for us to learn enough about one drug for one condition, another drug for another condition. I don't think it's fair to make patients wait when there is an option available. That's our approach, purely because of numbers. So in the last 5 or 6 years, we have now treated 50 plus patients, most of whom are children. Majority of them have LCH because that's what we see. Majority of them have the BRAF V600E mutation because that is the most common mutation. All the others have either a different BRAF mutation, like one example I showed you, or other mutations in MAP2K1. We initially were doing the same thing what Dr. Goyal said. If it was BRAF V600E, we would use a BRAF inhibitor. For all the others, we would use a MEK inhibitor. But now that we know this, and in order to learn about it, we've started using a MEK inhibitor for all of them. And fortunately, at least in our hands, every single patient has had a response. So the response rates are 100% in our hands. Now, what do I mean by response rate? I mean that the patient responded, okay? There is still more work to be done. So the most important thing, as Dr. Goyal mentioned, all of these patients are still on treatment. We have not stopped treatment, just like that French study he mentioned. We did try to stop it, but right away the disease came back. So we knew that we cannot stop it in everybody. We are currently developing assays that will tell us, we can actually measure tiny, tiny amounts of histiocytic cells in the bloodstream of patients, even when all the scans look normal. But if that blood test shows there's a cell, even a single cell left over, we know that the treatment must continue. This has already been covered. Are these drugs safe? They all have reported side effects in the adult population, especially melanoma. But as Dr. Franklin mentioned, most of in the melanoma experience, it's 2 drugs used together. We don't need to do that, so we have not been doing that. At least in children, we do not see fevers. With the BRAF inhibitor, the one that we've used is dabrafenib, and that's because there is, at least in my opinion, data to suggest that dabrafenib is better than vemurafenib, better tolerated. None of our patients had any side effects from dabrafenib. It was the miracle drug. With trametinib, several of them developed skin rashes. What we found is that if we reduced the dose, the rashes went away. So we just now start at the lower dose in everybody, because if the lower dose works, why not just use that? And with that, the rashes have become much fewer, much rarer, and much milder and easier to manage. But as Dr. Franklin mentioned, and Dr. Goyle mentioned this as well, we don't know what happens 10, 20 years from now. Some of the children in whom we started treatment, they are 6 months old. We don't know what happens when they will turn 40. So far, I have no reason to suspect that something bad will happen, but I'm honestly guessing. There's no data to tell us what to do. And how long do they need to be treated? These are all the questions we don't know. So how does one choose? As I mentioned, the BRAF inhibitors only work if you have BRAF V600E, whereas the MEK inhibitors work in almost every patient. There is an exception mentioned later because they block the next step in the pathway. And so we are using MEK inhibitors in all patients, and most of this, actually none of these drugs are approved in children. So we constantly are working and fighting with insurance companies, but not fighting anymore, in discussions. And the insurance companies, some of them have now recognized that, hey, this treatment actually works and it works better than chemotherapy. So they have now started approving it. But otherwise, we work directly with the drug manufacturers. And so far, because it's only a handful of children, they know that it's not going to cost them to give drug for free to a few handful of children each year. They've been giving us drug for free, directly shipping to the patient. The one exception that I mentioned, there is a class of mutations in the MEK gene itself, or MAP2K1, that is currently resistant to the available MEK inhibitors. And so if you were paying attention, BRAF goes to MEK, MEK goes to ERK. There are ERK inhibitors. There had been several that were tried, but majority of them could not be used because their side effects were just too horrible. There's one ERK inhibitor that is still available, and there is a tiny clinical trial that is currently being run by our colleague, Dr. Eli Diamond at Memorial Sloan Kettering. And he's using this ERK inhibitor for those patients who have this particular MEK mutation that is resistant to the currently available MEK inhibitors. And it's too early to tell, but at least it is working in stopping the relay. How beneficial and what the side effects are, they tolerable? That is the answer that I don't have. And so practically speaking, this is what we are now doing in all of our patients, and which is what Dr. Goyle mentioned. At any time that's possible, biopsy should be obtained, and then do the sequencing on that biopsy to find out what the mutation is. If you need treatment to begin right away, without knowing the mutation, you can start with a MEK inhibitor because it's going to work in most cases. And we start with a lower dose because we know that higher dose is going to likely cause reactions. If in spite of a lower dose, the rash still develops, we can go even lower. And by that, I mean, we start at what is considered half of the recommended dose, and we see a response even at a quarter of the recommended dose. Remember, these recommended doses come from experiences in clinical trials in cancers like melanoma. Histiocytic diseases are a little different. Even though they are cancers, they are severe, difficult challenges, but the biology is different. We can get away with lower doses of the drug. And if the rash still persists, just like Dr. Franklin mentioned, we have a protocol in place for how to manage the rash, and our dermatologists prefer to start with just a topical cream of this antibiotic called clindamycin. It seems to work whenever we've had to use it. But with us using lower doses, the rashes have become really, really rare. And if the side effects still continue, depending on what the mutation is, if it turns out it's a BRAF V600E mutation, you can switch to a BRAF inhibitor. Like I mentioned, dabrafenib has almost no side effects in our hands, or sometimes to a different MEK inhibitor. And if you come across this particular rare group of mutations, it's very rare, but it does happen. We've had a couple of patients. You can try an ERK inhibitor, but that still remains to be seen. That is all I had to say, and now thank you for your attention, and happy to answer any questions. Yeah, so we have not done treatment holidays because at least in LCH, within about 2 weeks, the disease starts to come back whenever we've taken a break. since we've started using lower doses, we are not seeing the side effects that we used to see with full dose. And even if we do see it, then we try and reduce it further. We try to go to every other day dosing, keeping the same. And that seems to work in majority of the children. Yes. Correct. Yeah. 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 This is a fascinating question. So the question is, if we are blocking this pathway for the cells to grow, these are immune cells, are we not jeopardizing our immune system's ability to fight off infections? Turns out that we have our biology, our cells, including our immune cells, have several different growth pathways, redundancies. And this does not seem to affect, so far in our experience, in any way, the ability for our immune system to fight off infections, which is what it is meant to do. None of the children we've treated have experienced any infections. In fact, we've tested them to, expose them to infectious agent. The best way to do that is by giving them a vaccination and see what happens. And they produce responses just like every other child. So I think what may be happening is that these mutant pathways are so sensitive to these drugs that they get blocked, but the normal cells that don't have these mutations can carry on without, because it's not like every immune cell is affected with this mutation. There's only a small group of them. So we still have several other normal cells, and the normal cells are not as sensitive to these inhibitors, especially the lower doses at which we use them. If we used higher doses, which is one of the advantages of these targeted therapies as opposed to chemotherapy, chemotherapy does not discriminate between a normal cell and a mutant cell. That is why we see side effects with those, but we don't see it with these inhibitors. Other questions? Yes, yes. Combination of BRAF and a MEK inhibitor? No, because biologically, to me, it has not made sense so far, because we know from our observations and from laboratory testing that using a MEK inhibitor does block it. So if it's not responding, then clearly I will go back and say, what are we missing? There's something wrong. If the data that we have is correct, then a MEK inhibitor should work, unless it is that mutation, the one there in the list on the bottom, this domain of the MEK gene does not respond to the currently available MEK inhibitors. All the others in our hands have always responded, unless we got the diagnosis wrong.
Dr. Ashish?
Thank you very much. That was very great.